Are you gearing up for radiology board exams? The Radiology Review wants to save you money. Visit our discount code section for current offers on Radiology Review recommended educational resources. Head to theradiologyreview.com and navigate to the discount code section. Terms and conditions apply. Limited time offer. Discounts may vary. Welcome to the Radiology Review podcast with your host, Dr. Matt Covington, a board-certified radiologist. For additional content, please follow the Radiology Review on social media, such as X or Instagram, at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website, theradiologyreview.com.
Welcome back to the Radiology Review podcast. On this episode, I will be discussing pediatric renal and adrenal masses for radiology board exams. This episode topic comes from listener requests, and I agree that this is a topic that is high yield for radiology board exams, so I am pleased to be able to cover this topic on the next 2 episodes. Once these episodes are published, you can download a free study guide on this topic available at theradiologyreview@gmail.com. Also, remember to check out the discount code section on my website, theradiologyreview.com, where I frequently have discounts on things like educational and board study resources that may be helpful for you. Without further ado, let's get into the questions and answers for this episode. First question: what is the most common pediatric renal tumor? The most common pediatric renal tumor is a Wilms tumor. This comprises around 85% of all pediatric renal tumors. Next question: what is the most common renal tumor in the neonatal age period specifically? While a Wilms tumor is overall the most common pediatric renal tumor, comprising around 85% of these, a Mesoblastic nephroma is the most common neonatal renal mass. I will discuss both of these entities in greater detail on this episode. Next question: true or false? A pediatric neuroblastoma is a pediatric renal tumor. This question is perhaps a little bit difficult, but the answer is false. And the reason why some of you may miss this is that a neuroblastoma is certainly a pediatric tumor, but it is not a tumor typically of the pediatric kidney. Neuroblastomas involve the adrenal gland and tissues of neural crest origin. Besides the adrenal glands, neuroblastomas can occur elsewhere in the retroperitoneum, such as the celiac axis or the so-called organ of Zuckerkandl, that is Zuckerkandl, as well as other sites, including the posterior mediastinum. Next, true or false? Renal cell carcinomas are rare in the pediatric population. The answer here is true. While renal cell carcinomas are a common tumor of the kidney in adults, renal cell carcinomas rarely occur in the pediatric population. A Wilms tumor is far more common in the pediatric population, as we've already discussed. When renal cell carcinomas do occur in the pediatric population, think about older children over 10 years of age and teenagers who nearly fall in that adult age range population. Next question: a Wilms tumor is most common at what pediatric age? Most Wilms tumors occur in early childhood, most typically around ages 3 to 5 years old. If remembering a single number will help you put this to memory, I would remember 4 years of age because that is at the center of the 3 to 5 year old age range, which is the key time at which a Wilms tumor is most commonly encountered. Next, true or false? Most Wilms tumors are bilateral. The answer here is false. Over 90% of Wilms tumors are unilateral, and paying attention in these pediatric renal processes to which tumors are unilateral and bilateral is actually fairly important for radiology board exams, so this is worth your time remembering in my opinion. Next, what is a classic clinical presentation for a Wilms tumor? Wilms tumors classically present as a painless mass in the upper lateral abdomen with possible associated hematuria and hypertension. Next, what are some classic genetic syndromes associated with Wilms tumor? There are many genetic syndromes associated with Wilms tumor, but among the most common genetic syndromes are Beckwith-Wiedemann syndrome, Wagner, that is W-A-G-R, as well as Denys-Drash, D-E-N-Y-S, Drash, and Sotos, S-O-T-O-S, syndromes. In general, it can be helpful to remember that Wilms tumors are associated with many syndromes. Next, what does Wagner, W-A-G-R, stand for in Wagner syndrome? I suspect that I have covered this on at least one prior podcast episode, but repetition can certainly be helpful, and this is a high-yield concept. So let's review it again. W-A-G-R. In Wagner syndrome, W is for Wilms tumor, A, aniridia, G, genitourinary anomalies, and R, retardation, meaning mental disability. Next, what are classic features of Beckwith-Wiedemann syndrome? Beckwith-Wiedemann syndrome is associated with congenital overgrowth, including macroglossia, hemihypertrophy, organomegaly involving organs like the kidneys, liver, and spleen, ear pits, omphalocele, and cardiac, renal, and genitourinary anomalies. The risk of malignancy is elevated in Beckwith-Wiedemann syndrome, with classic associations of Wilms tumors, neuroblastoma, hepatoblastoma, rhabdomyosarcoma, adrenal tumors, pancreatoblastomas, and others. Next, what are classic features of Denys-Drash syndrome? And again, this is spelled D-E-N-Y-S, Drash, D-R-A-S-H. What are classic features of Denys-Drash syndrome? Classic features of Denys-Drash syndrome include Wilms tumor, congenital nephropathy with glomerulonephritis, and male pseudohermaphroditism. It can be pretty challenging keeping these syndromes straight, and it may be helpful to review this in writing. So again, a free downloadable study guide is available for you if helpful at theradiologyreview@gmail.com. Next, what are classic imaging findings of Wilms tumors? Classic imaging features of a Wilms tumor include a large solid renal mass with heterogeneous appearance internally, including heterogeneous enhancement and smooth margins. A Wilms tumor may be partially cystic in appearance with areas of central necrosis, especially if large. Most have no calcifications, but internal calcifications can occasionally be present. CT scans sometimes show areas of internal fat density, and MRI can sometimes show areas of internal blood products. A Wilms tumor typically can cause mass effect on adjacent organs and may manifest on radiography as a soft tissue bowel displacing abdominal mass. Invasion and or extension into the renal vein and or inferior vena cava is possible. Next question. What are the most common sites of metastases with Wilms tumors? The most common site of distant metastasis in a Wilms tumor is the lung, followed by the liver. local extension into the adjacent renal vein and IVC, and sometimes the right atrium can be seen, and local regional spread to abdominal lymph nodes is common. Note that skeletal metastases are unusual for a Wilms tumor. Moving on, what is the hallmark pathologic finding of nephroblastomatosis? One of the challenges of the pediatric renal neoplasms, at least for myself, is keeping track of the names and the specific entities. Nephroblastomatosis comprises a condition where you have persistent nephrogenic rests, which are considered a hallmark pathologic feature of nephroblastomatosis. More specifically, persistent nephrogenic rests are sites of metanephric blastema that persist longer than 36 weeks of gestation. This can have multifocal or diffuse involvement of the pediatric kidney. Next question. True or false? Nephroblastomatosis has risk of malignant degeneration into a Wilms tumor. This answer is true. Wilms tumors can arise from sites of nephroblastomatosis. In cases of bilateral Wilms tumors, these nearly always arise from nephroblastomatosis with persistent nephrogenic rests. Next question. What are the classic imaging findings of nephroblastomatosis? If diffuse, nephroblastomatosis manifests on imaging as diffuse reniform enlargement of the kidney with a peripheral rind of thick tissue with striated enhancement characteristics. If focal, one would expect to see multiple peripheral nodules which are hypoechoic on ultrasound, hypodense on CT, demonstrate low signal on both T1 and T2 MRI, and enhance less than the normal renal parenchyma on both CT and MRI. Note that renal lymphoma can appear similarly, but would not be expected to occur in neonates and infants to the degree of something like nephroblastomatosis. Next question. What is the classic clinical presentation of a mesoblastic nephroma? As the most common neonatal renal tumor, the most common presentation of a mesoblastic nephroma is a palpable abdominal mass in a neonate, with symptoms such as hematuria being much less common. Most of these will be diagnosed within the first 3 months of life, and essentially all are found in the first year of life. Next question. What are classic imaging findings of a mesoblastic nephroma? Like other pediatric renal tumors, X-ray may show a soft tissue mass displacing the bowel. Ultrasound classically shows a circumscribed mass that may have concentric rings of varying echogenicity, with some rings appearing hypoechoic and others echogenic. Internal vascularity may be noted on color Doppler imaging. If there is internal hemorrhage or necrosis, internal heterogeneity can be seen with ultrasound. CT is typically not performed due to radiation risk in a neonate, but if it were performed, it would show solid, hypodense renal lesions without calcifications. MRI classically shows variable T1 signal and variable T2 signal within the renal lesions, but would be expected to show at least partial restricted diffusion in renal tumors. Next question. What is the key differentiator between a mesoblastic nephroma and a Wilms tumor? Age may be the key differentiator between these entities, with mesoblastic nephroma occurring in the neonatal period and first year of life, whereas Wilms tumors have peak incidence around 4 years of age. A very common board-style question on pediatric renal tumors does ask one to differentiate key features between Wilms tumors and other renal or adrenal tumors. So I would encourage you, and I have a few examples in this episode, that will help you pay attention to the difference between a Wilms tumor and other renal masses in the pediatric population. I also want to take a moment here to say that I have had 2 episodes previously on nuclear medicine renal imaging, and therefore I will largely not discuss nuclear medicine imaging of pediatric renal tumors in this episode, but would refer you to check out those other episodes on nuclear medicine renal imaging for review if helpful. Next question. True or false? Nearly all neuroblastomas contain calcifications. The answer here is true. Up to 90% of neuroblastomas contain calcifications. Next question. True or false? Nearly all Wilms tumors contain calcifications. So I have already given you the answer to this question earlier, and the answer here is false. Only around 10 to 15% of Wilms tumors contain calcifications. So the presence of calcifications within a tumor can help differentiate between something like a Wilms tumor in many cases and a neuroblastoma. Next, true or false? Neuroblastomas are usually unilateral. The answer here is false. Most neuroblastomas are bilateral. On the other hand, most Wilms tumors, as previously specified, are in fact unilateral. Next question. True or false? Neuroblastomas typically encase but do not invade vascular structures. The answer here is true. Neuroblastomas encase rather than invade vascular structures. A classic imaging appearance would be a mass lifting the aorta off of the vertebral column. Note, however, that more aggressive neuroblastomas can invade structures like the adjacent kidney and muscle. Next question. What age group is most common for neuroblastomas? The most common age group for development of neuroblastomas are young kids, such as those 2 years and under. Next, what tumor is more common to extend into the chest? A Wilms tumor or a neuroblastoma? Neuroblastomas more commonly extend into the chest. Next, true or false? A neuroblastoma is the most common childhood malignancy. The answer here is false. Many sources specify leukemia as the most common childhood malignancy, and brain tumors are the most common solid tumors in kids. However, I would remember that neuroblastomas are the most common extracranial solid tumor of childhood, and as such expect many potential questions on neuroblastomas on radiology board exams. Next, what is so-called Pepper syndrome of neuroblastoma? Pepper syndrome is an adrenal neuroblastoma with hepatomegaly due to extensive hepatic metastases. And that leads us to the next question. What is the stage of neuroblastoma for a pediatric patient with Pepper syndrome? The answer here is stage 4S, and I would pay attention to stage 4S neuroblastoma because it has some specific nuances that are high yield for radiology board exams. So, next question, what are the features of stage 4S neuroblastoma? The S in 4S is for special, and stage 4S neuroblastoma is the special type of neuroblastoma. As such, like I said, expect questions on this entity on board exams. Stage 4S neuroblastoma occurs in pediatric patients under 1 year of age with localized primary tumors and distant metastases only involving liver, skin, and/or bone marrow. Stage 4S tumors are special in that they have an up to 90% 3-year survival, which is approximately the same as stage 1 or 2 disease. This is in comparison to a much worse 3-year survival for non-special stage 4 disease. Note with the non-special stage 4 neuroblastoma that those over 1 year of age have dismal survival at 3 years of only something like 15%. In comparison, patients under 1 year of age with stage 4S neuroblastoma have a 3-year survival of up to 75%. Next question. True or false? Most neuroblastoma patients present with stage 1 or 2 disease. The answer here is unfortunately false. Up to 75% of neuroblastomas present with stage 3 or stage 4 tumors. Next, what is so-called blueberry muffin syndrome? Blueberry muffin syndrome is more broad than neuroblastoma alone, but includes neuroblastoma. Blueberry muffin syndrome is a classic skin appearance in pediatric patients with multiple blue to purple cutaneous lesions, which are associated with neuroblastomas, leukemias, and other hematologic disorders, as well as viral infections like cytomegalovirus and congenital rubella. This is a form of extramedullary hematopoiesis of the skin, and when one sees it, one needs to consider the potential that neuroblastoma or another malignant or hematologic or viral process is an underlying cause or association. Next, what is so-called Hutchinson syndrome? It is difficult keeping all of these syndromes that are named straight, and that is why I am reviewing these briefly. Hutchinson syndrome is neuroblastoma with bone metastases causing clinical symptoms of bone pain and limping, as well as proptosis and periorbital disease involvement, which can include the so-called raccoon eyes. If you do not know what raccoon eyes look like, please look this up. Next, what is the term for the jerking eye movements, cerebellar ataxia, and myoclonic jerking that in a pediatric patient is strongly associated with neuroblastoma? The answer I am looking for is opsomyoclonus. That is spelled OPSOMYOCLONUS. This is essentially an autoimmune-like paraneoplastic phenomenon that can occur in pediatric patients with neuroblastoma. Last and final question for this episode. What are key features that can help differentiate a rhabdoid tumor, that is RHABDOID, rhabdoid tumor of the kidney, from a Wilms tumor? Like neuroblastomas, rhabdoid tumors also are more common in children less than 2 years of age, whereas Wilms tumors most commonly present in slightly older children of about 3 to 5 years of age. About 2/3 of rhabdoid tumors have calcification, compared to around 10 to 15% of Wilms tumors. Rhabdoid tumors tend to be very aggressive, so one may expect to see vascular invasion, central necrosis, hemorrhage, and subcapsular fluid collections. That is enough for now. I hope these questions and answers have been helpful for many of you. On the next episode, I will focus especially on some of the cystic pediatric neoplasms that can occur in the kidney, and these are also high yield for radiology board exams, so make sure and check that out. Remember to download the free study guide at theradiologyreview.com if that is helpful for you, and spend some time on the website to see other educational radiology content that is available there. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
What's better than listening to the Radiology Review?
Nothing.
Well, true. But you could buy our book, The Board Exam Study Guide, Episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.